Welcome all of you to this live program at Orthopedic Principles. Today our guest of honor is Professor Michael Hantes from Larissa, Greece. Michael Hantes is a professor of orthopedic surgery at the University of Thessaly in Larissa. Professor Hantes completed his medical degree at the Aristotle University of Thessaloniki in 1990. He trained in orthopedic surgery at the Anna University Hospital, followed by fellowship training in sports medicine and knee arthroscopy at Heidelberg in Germany, followed by an upper extremity and knee arthroscopy fellowship with James Chow in the United States. Professor Hantes is the founder of the Larissa Arthroscopy and Minimally Invasive Center and organizes seminars in arthroscopic surgery, clinical practice, and research of Professor Hantes focused on knee and shoulder. He has been the president of the Greek Arthroscopy Association and Sports Medicine, and Professor Hantes is an active member of the ESSKA, where he has served as the treasurer, the secretary general, and currently the first vice president of ESSKA. If you've noticed, Professor Hantes has delivered several lectures on the channel, and today is my great honor to bring back Professor Michael Hantes for this wonderful live program. Over to you, Professor.
Thank you very much, Hantes, for the kind invitation. It's always a pleasure to be with you to this Orthopedic Principles channel. So today, my topic is management of post-meniscectomy syndrome. And let's have a look how we can diagnose and manage properly this condition, which I would say it's not a rare condition. So these are my disclosures, but nothing to do with this presentation. So what is a post-meniscectomy syndrome? Post-meniscectomy syndrome is defined as pain occurring in a previously meniscectomized knee, either in the medial or the lateral compartment, in a relatively, I would say, short period of time, up 1 year to 5 years, maybe more, after meniscectomy. And the characteristic of this post-meniscectomy syndrome is pain. So why this happens, let's try to explain based on biomechanics. As we know, the lateral meniscus is thought to carry approximately 70% of the load in the lateral compartment, and the medial less, which is close to 50% of the load in the medial compartment. And we will see later why this is very important. Another important thing, especially in the lateral compartment, is, as you can see in this nice figures, that both the tibial cartilage and the subchondral bone plate, especially in the lateral compartment, it's about 4-fold thinner in comparison to the central region. And if you take into account that this peripheral region is covered by the meniscus, if you remove the meniscus, you can imagine how the load and the shear forces will increase in this, I would say, sensitive area. So this is an example of a very young 18 years old soccer player who had at the age of 16, believe it or not, subtotal lateral meniscectomy. As you can see, there is almost no meniscus in the lateral compartment. And this is his arthroscopic view 2 years, just 2 years after subtotal lateral meniscus. You can see the lateral compartment. He has developed already cartilage lesions both in the tibia and in the femur. And this is, of course, something very, very difficult to manage and to accept for such a young boy. So, as we said before, the main symptom is pain in the post-meniscectomy syndrome, which is the result of overload due to meniscus loss. Probably the symptoms are directly related to the amount of meniscal tissue that has been removed. And based on what we said before, lateral meniscectomy produces more often pain and functional problems, and in a relatively short period of time. I mean, somebody can go well after a medial meniscectomy, but this is not the same for lateral meniscectomy. So what is the management of this syndrome is, of course, to manage the meniscal tissue loss, which can be performed in two ways, either with meniscal allograft transplantation after a total or subtotal meniscectomy, or using meniscal scaffolds in cases of partial meniscectomy. Of course, you don't have to repeat another meniscectomy if a patient has pain after a previous meniscectomy. Believe it or not, this is, I would not say common practice, but it's something that happened very often. At least this is my experience. And this is a 25-year-old soccer player who underwent a lateral meniscectomy, and because he developed pain, he underwent another second meniscectomy. And of course, you don't expect that the second meniscectomy will solve the problem. And you can see the severe cartilage lesions that have been developed in this patient. Of course, it's not only the meniscus tissue loss. You have to prioritize your treatment, and in order to treat the patient in a proper way, you have to take into account the alignment, you have to take into account the ligament stability, and then comes the meniscus defect, and finally the cartilage. This means that you cannot apply meniscus transplantation in a varus knee or in an unstable knee without correcting before the alignment or providing stability to the knee. So going back to management of meniscus tissue loss, you can use, as we said, in cases of partial meniscectomy, the so-called meniscus scaffolds. This is the first meniscal scaffold that has been used and is in the market something like 30 years. The so-called collagen meniscus implant, the CMI, it's a bovine collagen scaffold, and it was, of course, the first to have been released in the market with more than now 20 years follow-up, I would say. However, it has some limitations because it has a rapid degradation. The origin is bovine, and finally, it's difficulty in its handling. For those who have used this scaffold, they are very well known that there is really a difficulty in handling this material. And that's why another meniscus scaffold, the ActiFit, came into place, which at least in theory, it's better than the CMI. This is a scaffold which consists of polymer, and within the polymer there are softer polycarbolactone segments that constitute 80% of the polymer, and the remaining 20% is a more rigid urethane. And the difference between the ActiFit and the CMI is that the hydrolysis of the polycarbolactone lasts up to 5 years, which means that this gives enough time to the knee to replace, let's say, the meniscus. So, of course, it comes in two configurations, for medial and lateral meniscus, as you can see. And in theory, both of the scaffolds act as a template for proliferation, and with the so-called creeping substitution, the scaffold is replaced by cells coming from the surrounding tissues and the host. And at least in theory, as we said, the scaffold slowly degrades and replaced by a meniscus-like tissue. Once again, the indications are for partial loss or for lateral or medial meniscus. You have to have an intact anterior and posterior horn and an intact rim at least 2 millimeters. And it's good to have not severe cartilage lesions more than third degree. And the age is something that we can discuss, but in general, we don't use it in ages less than 16 years old or more than 50 years old. So This is probably a good example of indication of a meniscus scaffold. It's a fully arthroscopic technique, and the technique is performed through standard anterolateral and anteromedial portals, and the remaining meniscus is trimmed, and then the meniscus defect is measured with a roulette, and the scaffold is placed in the defect to better fit the defect. It's always good to oversize the scaffold. So this is an example of an active fit meniscus scaffold. After measurement, you can cut the desired amount of scaffold that is going to be used. And then, as we can see in the video, you implant it into the joint carefully, into the defect. So this is the first step, the implant insertion. This was a big defect, but with intact anterior and posterior rim, as you can see in the video. And then you're starting to suture the scaffold into the remaining meniscus and into the intact meniscus by using inside-out sutures for the body, for the middle part of the meniscus and the anterior horn. And then for the posterior horn, usually you use an all-inside technique by using different type of all-inside devices. As you can see, here it's a device which contains 4 implants, which gives you more flexibility to put the all-inside in the posterior horn by not using so many devices. And this is the example that we discussed before, 25 years old soccer plane with normal alignment. This is the defect which has been replaced by the ActiveFit scaffold. This is after scaffold implantation, and we did as well a chondroplasty. And this is the MRI 12 months post-op. And this is the second look arthroscopy 1 year after the implantation of the meniscus scaffold ActiveFit. You can see in the right-hand side the situation of the lateral compartment before, and now we're going to see how it looks 1 year after the implantation. You can see the scaffold in place, and the cartilage lesions has been partially, I would say, healed, as you can see, but the situation, it's much, much better in comparison to the pre-op image. So hopefully this scaffold will be replaced by meniscus-like tissue in the future. But I would say that, as you can see in the second look arthroscopy, that in general, the knee condition is I would say, acceptable. So what are the results after this procedure using the collagen meniscus scaffold? Definitely from a clinical point of view, as we observe, the pain decreases significantly. The functional results regarding all PROMs, LISOM, IKDC, improved significantly as well. The greatest improvement is achieved during the first 2 years post-operatively. However, there is a significant amount of failure, which is between 5 to 25%. The MRI results are not so good because you always observe some meniscus extrusion. The implant in many times is seen as a structure of intermediate signal intensity, and sometimes you can observe absorption of the implant, like in this case. So this is more or less, I would say, a common finding in MRI after ActiveFit scaffold implantation. And this is the MRI images in 2 years and in 5 years. So once again, this is the MRI 12 months post-op. And this is another case of an MRI 1 year post-op. You can hardly see the implant in the posterior horn of the medial meniscus, which could be probably due to very slow maturation process or to failure of incorporation or because of you need more time to either have a more mature stage of the implant in a long-term follow-up. These are our results from our department, which has been published some time ago. This is the long-term results and MRI outcomes as well. We had a minimum follow-up of almost 11 years. As you can see, Loiy course and technical score improved significantly. However, regarding the MRI results using the so-called Genovese classification showed that the 23 knees had type 2 scaffolds and the rest were type 3 or type 1, which is not, I would say, ideal. And of course, the other option is meniscus allograft transplantation. This is a procedure that has been performed first in animal and then in human in early 80s, and that's why it is considered not an experimental surgery anymore, because we have more than 20, 30 years of follow-up. So the question, of course, once again, is about indication. Who is the right patient to get a meniscus transplantation? These are the indications for meniscus transplantation: unicompartmental pain in the presence of total or subtotal meniscectomy, as a concomitant procedure to revision ACL reconstruction in a previously meniscectomized knee, or as a concomitant procedure with articular cartilage repair in a meniscus deficient compartment. So the question is if this procedure should be considered as a routine procedure in an asymptomatic patient. For example, if you have a 70-year-old who had a previous lateral meniscectomy, should we do a meniscus transplantation in this patient? Based on the group of surgeons who are very experienced in these procedures, as you can see, 42 of the surgeons believe that in general would not do a meniscus transplantation in an asymptomatic patient. Probably some of them would perform a meniscus transplantation, but only for the lateral meniscus. And as you can see, the vast majority would not perform a meniscus transplantation in an asymptomatic patient. Some of them probably for the lateral meniscus. So keep that in mind, that for an asymptomatic knee, it's a question, I would say, if we proceed with a meniscus transplantation. So, of course, we discuss about young patients, not old patients. The age is something that we can discuss. Probably the age limit is something 50, 45, 55. It's good to have a BMI less than, I would say, 30, not 35. And of course, we have to discuss with the patient the expectation. It's a procedure that will not probably keep you in a position to be back in sports, but it's to improve the quality of life. Of course, another important factor is the cartilage lesions. As we know, if you have grade 3 or grade 2 outer bridge lesions, then the results of meniscus transplantation in these patients, as reported in the literature, it's not as good as you have with intact cartilage or minor cartilage lesions. As you can see, 94% survival rate for low-grade chondral lesions, in contrast to 62% survival rate for severe cartilage lesions. So this is something that you have to take always into consideration, and when discuss pre-op with the patient the expectations of meniscus transplantation. Of course, as we said in the beginning, a realignment osteotomy should be considered if there is a mechanical axis deviation. This is out of question. And some things about the surgical technique. You have to prepare the graft. In our country, at least, we order the graft and we import it from United States. We sizing the graft, and then if the bank tissue has a graft based on our measurements, we order the graft and we implant it, the graft to the patient 1 day before the arrival of after the arrival of the graft. These are the storage methods of the graft, but I don't want to spend so much time on this issue. In general, there are fresh viable grafts, fresh frozen grafts, and cryopreserved grafts, and lyophilized grafts. Everyone has its advantages and disadvantages, but in general today we used fresh frozen grafts. This is the preference of the vast majority of the surgeons, mine as well, and actually we don't use cryopreserved or lyophilized grafts today. Regarding size of the graft, you can do it either with the X-rays, using the so-called polar method, which takes into account the width and the length of the meniscus, or by using the MRI, because the polar method has a mean error of approximately 10%, and this is something that sometimes creates problem. So in my practice, we're using the MRI of the affected knee and measure the dimensions of the meniscus, and then we proceed with graft order. Then regarding surgical technique, you can use the so-called suture-only fixation, bone plug fixation, or the keyhole technique. All these techniques are performed either by arthroscopic means or open or semi-open techniques. And regarding the results and which technique is better, there are many papers which report that there are no difference between the three techniques, the suture-only technique, the bone plug, or the bone bridge technique. So this is a video of a surgical technique for meniscus transplantation. This is a young boy. As you can see, there is almost no meniscus in the lateral compartment. I'm using this microfracture awl to do some trephination and vascular channels. This is the tunnel for the posterior root of the meniscus. You can use a guide and then pass the sutures. First, you start with posterior tunnel, and then you pass the suture, and then, as you can see, you proceed with the anterior tunnel, which is close to the ACL. So you have to pay attention in order not to disturb, I would say, the ACL, either the native ACL or the ACL graft, and then you pass the other suture. I'm using one more suture in order to help me to introduce the implant into the joint. As you can see, in this case, there are no severe cartilage lesions, so I would say it's an ideal indication in terms of cartilage lesion. And now we're trying to import the implant into the joint, which is probably the most difficult part. This is the implant placed into the joint, and then you can start to stabilize the transplant by using a lot of sutures. I'm starting with inside-out sutures in the middle part of the meniscus, and placing a lot of sutures in the tibial and the femoral surface as well. As you can see, I alternate the sutures in both surfaces, and then at the end, I'm putting the all-inside implants in the posterior part of the meniscus. Once again, my preference is to use an all-inside implant which contains 4 implants, and this gives me flexibility to better stabilize the meniscus. And this is in most of the times the final part of the fixation. And as you can see, the meniscus is in place after stabilizing the anterior, middle, and posterior part of the meniscus. Regarding the results are really very good. Based on the literature, you can expect a 70% survivorship at 10 years, and with significant improvement in all PROMs and pain as well. And as you can see, as the times goes by, the survival rate reduces, and it can be almost 40–50% at 15 years, which is, I would say, a very good result. So, we were at reporting the results of the meniscus transplantation,
Yes.
and based on the literature, you can expect even a return to sports after meniscus transplantation. Based on this paper from Marcazzi from Bologna, Italy, as you can see, 92% return to play, but we're talking about professional soccer players. I would say in general, the return to play rate is between 40–70%, which is once again a very good rate. So this is our result and our paper, which has been published some years ago, which describes the results of meniscus allograft transplantation in isolation or combined with ACL reconstruction plus lateral extra-articular tenodesis. And as you can see, both of the results were good based on the meniscus transplantation, but especially when you do an isolated meniscus transplantation, you can expect better results in comparison to a combined procedure. So, and of course, the arthritis development after meniscectomy, it could be considered as a painful condition, and probably as post-meniscectomy syndrome, but we're not going to spend so much time on that. And of course, in this case, you have to correct the alignment. You have to respect the indications in order to do a realignment osteotomy when you have a meniscus defect and malalignment of the limb. And the planning for that is very well known. It is not my intention to spend a lot of time about planning for meniscus, for tibial osteotomy, but all these measurements, the medial proximal tibial angle, the lateral tibial femoral angle, the overall alignment should be taken into account. And then you go for an osteotomy using using a plate. The question is if it's necessary to perform a meniscus transplantation in addition to a realignment osteotomy. So this is something that it's a controversial topic. This is a patient of 42 years old with a medial meniscectomy 11 years ago. As you can see, he already developed knee arthritis. So the question is, high tibial osteotomy only plus meniscal transplantation or just high tibial osteotomy? As you can see, this is a study which reports that there are no differences regarding meniscus transplantation or meniscus transplantation plus osteotomy. So this is an example of a 36-year-old male who had a lateral meniscectomy and ACL reconstruction, if you can call this procedure ACL reconstruction. So what we did just a distal femoral osteotomy because of advanced arthritis, and this is the result of the patient. This is pre-op, and this is post-op. As you can see, the thrust in his gait has been corrected, and the patient is very happy. However, especially for the lateral compartment, it's sometimes important to do both procedures, distal femoral osteotomy, especially for a valgus knee, and meniscus transplantation, like in this case. But in general, I would say for the medial compartment, high tibial osteotomy works very well, even without meniscus transplantation. And these are some examples of meniscus resection many years ago, and the high tibial osteotomy, and the patients are doing really very well, even 10, 12 years after high tibial osteotomy. And these are our results of high tibial osteotomy in patients who have been meniscectomized in the past. And as you can see, the results are really very good in a follow-up of more than 10 years. So in conclusion, I would say that for the post-meniscectomy syndrome, meniscal scaffold is a good option because it improves significantly the knee function, mainly pain and activity level. We still have a high failure rate. The MRI results, I would say, are not ideal, and based on the MRI results, I would say that this procedure does not reproduce a meniscus-like tissue, and comparative studies are needed to see if really, in comparison to meniscus transplantation, is an operation that it's more inferior. Definitely meniscus transplantation should be reserved for symptomatic total or subtotal meniscectomy. It has really very good outcomes, and especially the lateral meniscus transplantation has better outcomes and less failure comparison to medial meniscus transplantation. And in order to have a good result, you have to take into account the cartilage. Ideally, you have to manage the patient with low-grade chondral lesions in order to have a long-term good result. And of course, in advanced cases, high tibial osteotomy is something that you can, of course, use it in order to give the best result to the patient. And it's not clear from the current studies whether combining high tibial osteotomy with meniscus transplantation will give you a better result. At least in my perspective, I would not do it for the medial compartment, but I will keep it for the lateral compartment in young patients. I mean, lateral meniscus transplantation plus osteotomy, but for the medial compartment, I think high tibial osteotomy to correct varus is enough. And of course, we're looking forward to welcoming you, all of you, in Prague for the next ESSKA Congress in a few days, I would say, May 20th to 22nd. And we're really looking forward to see all of you in Prague. So thank you very much. We had some problems, but I think at the end we did it. So thank you very much.
Thank you, Prof. Prof, you can stop sharing.
Yeah, just a moment.
Thank you, Prof, for yet another cutting-edge presentation.
I'm sorry. I'm sorry for the problems, but anyway, I think we managed it.
Yeah, thank you very much, Prof, for the cutting-edge presentation. Meniscal scaffold and meniscal transplant are something new for a lot of people all over the world. Some people have access to both. Some people have access to neither.
Yeah, this is really a big problem. I mean, we don't have a tissue bank in our country, and we import them, the meniscus transplants, from the United States. It's really very expensive. It's an expensive operation. And I think in general in Europe, very few countries have their own tissue bank, and for them, it's not so expensive. But in general, it's a demanding operation, an expensive operation, and requires a lot of experience. And my recommendation is to go close to somebody who is doing a lot of these procedures. And finally, you will be familiarized with the procedure.
Yeah, thanks, Prof. Prof, I think in Italy they're doing right in Bologna, if I'm right. Alberto Grassi
Yeah,
and Professor
in Bologna,
Zavagnini, Stefano.
in Bologna, in Bologna and in Barcelona, they have their own tissue bank in Italy and Spain, so they are lucky. And the availability of the graft, it's definitely better and easier in comparison to the rest of the European countries. So this makes a big difference, and they can use it, I would say, not massively, but in a lot of patients.
Prof, is there a role for these procedures, the scaffold as well as the transplant, in a degenerated knee? I'm not talking about a post-meniscectomized knee, but in a degenerated knee that is not yet into a fully blown arthritis. There is some male meniscal damage, there is extrusion. Do you think, for example, it can evolve into a treatment for osteoarthritis?
I would say, based on the current literature, based on our experience, I would say no. I mean, if you have advanced cartilage lesions, the knee is already arthritic, and if it has a malalignment at the same time, then the osteotomy works really very well. And as I told to during my presentation, at least for me, there is no indication or limited indication to do at the same time for a varus knee, a high tibial osteotomy, and meniscus transplantation, because the osteotomy works really very well. But for the lateral compartment, if you have a young patient who did not develop severe cartilage lesions, then it's most probably worthwhile to do both. Osteotomy plus meniscus transplantation. But in general, to go back to your question, I would not say that it's indicated in cases of an arthritic knee, because most probably the patient will not benefit from this procedure.
And Prof, you mentioned that it goes well with an ACLR and an LET and also with an HTO. So will a
Yeah,
meniscal transplant go well with the cartilage procedure as well?
yeah. I mean, when you have combined procedures like ACL revision, which is something common, I would say, and do a lateral tenodesis to give more stability to the knee. So when you have combined procedures like ACL revision, meniscus transplantation, and lateral tenodesis, the results are still good, but in comparison to isolated meniscus transplantation, I think it's a little bit inferior. But still, the functional result and the knee function, it's really good even after combining procedures.
And Prof, given a choice between scaffold and a transplant, how do you decide who gets a scaffold and who gets a
Yeah.
transplant?
This is a very good question. This is a very good question. And I would say that in the last years, I'm moving more and more to meniscus transplantation. In the past, based on the availability as well, the cost, I would say that I used more meniscus scaffolds. Definitely, it should be a knee with a limited meniscectomy with intact anterior and posterior horn. But based on the MRI results, based on the long-term results, based on the failure rate, I would say that today my preference is more and more for meniscus transplantation.
And which one do you have better results, the lateral one or the medial one?
The lateral one. The lateral
Lateral
because
one gives.
yeah, because patients had pre-op more functional problems, more pain, and the result after the lateral meniscus transplantation, it's really impressive. Sometimes patients feel very good, and many times they get back to sports, and they're almost free of symptoms for many years.
Thank you, Prof. Prof, what about the age? What age would you prefer doing the allograft or the scaffold?
Yeah, AIDS is always a question. I would say for a meniscus transplantation, my upper limit would be 55 years maximum, especially if you have a high demand patient who is doing a lot of things, I would not hesitate to do a meniscus transplantation. If I have a small segmental defect, I would prefer to proceed with a meniscus scaffold, but in general, not the upper age limit for scaffold, it's a little bit lower, 40 years old, I would say.
Thank you, Prof. Prof, I think that's all the questions that we have for this session. Thank you for yet another fantastic presentation and best wishes for the Congress. You're going to be the
Thank you very
president
much. Thank you very
from
much for
Prague
the
to Sweden.
invitation. Once again, Hantes, and once again, looking forward to welcome all of you in Prague. Thank you very much.
And I'm also, Professor Hantes, I'm very honored to have two vice presidents back to back. I just hosted Bertie 2 weeks ago, and you are going to be the president, and she's going to be the first vice president of ESSKA. It's a great honor.
That's very good. This means that ESSKA is very close to you.
Thank you so much, Prof. Bye-bye.
Thank you very much.